My name is Adelola Adeloya, Professor of Neurological Surgery, University of Ibadan, and Chief of Neurosurgery in the University College Hospital, Ibadan, Nigeria.
My name is Gerishom Sande, Professor of Neurosurgery, the University of Nairobi, and Head of Neurosurgery, the Kenyatta National Hospital in Nairobi.
Professor Sande, it is my pleasure to be talking to you here. And before we continue, can you give us an idea of why you went into the medical career?
That's a difficult question. I really cannot remember. I'm on the old side now. I can't remember what I thought like when I was a young man. But you see, I was born in a village in Kenya, far away from any medical facility. The first contact I had with somebody in a white coat, medical people tend to be in white coats, was when I was about 8 years old. And this was a medical assistant relative of mine. And this man would come home, and every time he came home, he gave us injections. I have no idea what they were for. I think they were for malaria. That frightened me initially. But with time, I suppose, to appreciate that it was useful that he gave us those injections. I eventually went to secondary school and therefore had a little more contact with the hospital people. I didn't do too badly at secondary school. And in those days, you had to do well to go into medicine. Finally, I did pass my exams. I had to write down what I wanted to do. And my headmaster said, well, I was doing well enough to pass well, to go into medicine, go into law, go into anything I wanted. But really, my headmaster wanted me to go and teach, to go into teaching. I suppose a headmaster is a teacher, so he wants his best students to go into teaching. I chose medicine, did well in science, and was accepted at Makerere for medicine.
Thank you very much. This is a good story of medical education in Africa, that we are fortunate that in most parts of Africa, our best students in the secondary school level have tended to go into medicine. Now, you went on to train in neurosurgery. Would you mind telling us where you trained and your experiences there?
You see, after Makerere, I went back to Nairobi for internship, worked in Mombasa for the surgical part of my internship, and there was no neurological surgeon there. I had to deal, even as an intern, with the broad spectrum of pathology, largely trauma, emergency trauma, and did, in fact, my first operation in the head as an intern. As later on, of course, I then went on to specialize in surgery, perhaps because I did internship in an area, in a town where there weren't many surgeons, and I had opportunity to do a lot of things on my own. My surgical training was such that I was supposed to spend 3 months in neurosurgical training. I ended up spending 9 months, which allowed me to have a little more experience in neurosurgery. At that time, in Nairobi, there was no full-time neurosurgeon. There was one neurosurgeon who did part-time at our hospital, a 1,000-bed hospital. And working with him for 9 months meant that I did most of the work. So again, it was that sort of occasion that enabled me to do this. And after I got my master's in medicine in Makerere, I went on to a provincial hospital as a provincial surgeon worked there for 6 months, had opportunity to develop an interest in neurosurgery, applied to join the medical school as a lecturer, and was taken in as a lecturer with an interest in neurosurgery.
Yes.
By that time, a full-time neurological surgeon had been recruited to the medical school, and I worked with him for 3 years. Then went on to Belfast at the Queen Victoria.
Yes.
In those days, Belfast was a good place because quite a few people turned up with bullets through their brains, and it was a good station to learn this sort of work at. From Belfast, I went to Glasgow and worked under Professor Jeanette. In Belfast, it was Mr. Eric Gordon that taught me, and Mr. Bailey was there too. I went on to Glasgow and worked under Professor Jeanette, the head injury firm,
Yes.
and Mr. Tisdale, who is now Professor of Neurosurgery in Glasgow. And then came back home and rejoined my unit of neurosurgery in Kenyatta.
Very good. Thank you very much. So the statement that military experience provides a good training for surgeons, and maybe particularly for neurosurgeons, is quite true, because I have the same experience myself, that when I went back home to Nigeria during our civil war, we had to do a lot of military neurosurgery, which involved a lot of head injury, like you did in Belfast.
Right.
Now, will you please tell us what types of cases you encounter now in your practice in Africa?
I like that question because it presupposes that things are different in Africa from elsewhere. There is trauma. We have a large amount of trauma, largely from our wars. My experience in Belfast did help when we had trouble at home and there was a lot of shooting right and left and center and in between. So the group of trauma is a large one. Then, when I worked in Glasgow, the question of vascular disease, aneurysms, was common. This is not common in our environment. We have the tumors, brain tumors, tumors of the cord, these are common. What is different from my Glasgow experience is the infective conditions. Brain abscesses are much commoner in our environment than they were in Glasgow and Belfast. Congenital malformations, perhaps as common as I did see elsewhere. Problems of the spinal cord, perhaps just as common as I did see elsewhere.
Yes.
Right.
Do you see any differences in your practice in Kenya from other parts of the continent?
Well, I haven't had much work. I haven't really worked anywhere else in the continent, but from what I hear at conferences and from discussions with colleagues from elsewhere in the continent, most of our problems are the same. The differences are in detail. The differences are in facilities, investigative facilities, and operative management facilities that I may have and they don't have, or they have and I don't have.
Yes. I ask this question because the pattern of diseases that you've just described is closely similar to what we see too in West Africa. The aneurysms are rare. The acoustic neuroma is almost unknown. And we see infective cases too. Would you like to tell us something about your research activities or facilities for research in neurosurgery in your part of Africa?
Now, we have problems with high-tech research facilities, But that is not our problem just now. Our problem just now is to document the type of problems we see, the type of problems that exist in our communities. So there we have no problem. We are at the moment mapping out the frequency of congenital malformations in our community and attempting to compare these and relate these to the environment. So that we don't really, for that we don't really need much in the way of high-tech research facilities. We are also currently involved in assessing the level, how much of our road traffic accidents we can reduce. Our road traffic accident level in Kenya is very high indeed. And most of our problems, admissions in hospital, relate to injuries on the spinal cord, but particularly injury to the head.
Yes.
In Kenya, we are now encouraging people to wear safety belts. It is not yet mandatory that these are one. Hopefully it will be soon. We are again working on that one. We are documenting our incidence of intracranial tumors because of the experience around. It would appear that the incidence of tumors in the head is different from place to place. And we are attempting to document this at the present time.
So the thrust of your research at the moment is clinical.
Correct.
Just like in most parts of Africa. But talking personally, when you are in Belfast or in Glasgow, you do have any facilities to do any experimental work or on your own?
Yes. In Glasgow, I spent a lot of time doing intracranial pressure monitoring in patients with head injury and assessing this. Glasgow is really the center in Britain for head injury research. We worked on the changes in the blood chemistry in head injured patients. In Belfast, it was largely we did work on the effects of bullet wounds to the brain and studied the brain with respect to this.
So this is still the position too in most parts of Africa that we do not have facilities or maybe the time for esoteric experimental work. Our work at the moment is purely clinical.
Yes. Yes, I should have added that the load of clinical work is such that the amount of research one can do, you have a very high load of clinical work. There aren't many of us around, so you can't take time off to do research. So the amount of clinical work the amount of research one can do is limited.
Yes. Yes, I agree entirely. In my own experience, I had to go away for a year to be able to do a little experimental work. I had a Rockefeller fellowship which took me to North America to the Children's Hospital Research Foundation in Cincinnati to do some work on congenital malformations, and to Sheffield in England to study the morphology of spinal bifida cystica. But on coming back home, clinical work has been so much that we have not been able to continue that. Would you now like to tell us other problems or any other special problems that you are encountering in the development or practice of neurosurgery in Kenya?
Well, problems are many, and one doesn't really like discussing problems. One likes to discuss the brighter aspects of neurosurgery, because neurosurgery is essentially a bright area of work.
Thank you for saying that.
But you see, today you go to conferences and people are talking about the results in relation to very sophisticated investigative facilities. These are not generally available in our environment. Our patients have to travel long distances because they have to travel long distances, they often come to hospital late. Now, I do not say that patients come to hospital late. They usually would come to a health center, to a dispensary. They are given aspirin because they are so far from a referral hospital that being referred is a problem. The person referring is concerned that he should send this man so far away from home. So eventually, by the time a decision is taken to refer the patient, it is 6 months, and the problem has advanced to a level where perhaps the help that would have been available is no longer adequately available.
Yes.
Patients come to the specialist centers late. Those who would have managed and helped completely, cured completely, are no longer curable. The numbers of specialized centers is small. This is why people have to go to travel long distances. The number of personnel, not just neurosurgeons, even the specialized nurses are a few. Occupational therapists are a few. But I think all in all, in my own country, we are addressing this adequately at the moment. We have now a neurosurgical center in Nairobi. We expect that one will be established in Mombasa. That's the cost. I hope you know,
yes.
Kenya.
Yes.
In Mombasa, we expect that we'll have a neurosurgical center soon, and we anticipate after we establish that one, that we'll establish another one towards the west at the lake, the town of Kisumu. So we are proceeding in this way.
Yes, very good. So we must congratulate you on the steps that you are taking to advance neurosurgery in Kenya.
Thank you.
There is still the problem in parts of Africa of governments and colleagues looking on neurosurgery as a super specialty that should be just put aside while other areas develop. Now, what about training? Because if you're going to have centers in outside Nairobi, centers in Mombasa and the other big cities of Kenya, you will need personnel. What are you doing about this?
Yes, this is the initial problem you raised. I think we have overcome in Kenya. The feeling that this is a super specialized area, and every time you say we need more beds, the other specialists feel that you are building a kingdom. I think we are overcoming that. Now, we have a postgraduate school in Nairobi, University of Nairobi. And here what we do in the way of training is that a man, we haven't got a woman yet, so let me talk about a man.
We wait
yes,
for that.
Yes, a man who has done the postgraduate course and done well, obtained his master's degree in surgery, would go out, usually posted the Ministry of Health, to a provincial hospital for about 6 months. Then, having expressed interest during his training, interest in neurosurgery, he would come back to us and we train him through the basic areas of neurosurgery, usually offer him adequate practical experience, practical operative experience for 2 to 3 years. Then after this period, we have arrangements with various facilities in Britain, and we would send him across, send one to Glasgow. We have had one come back from, the one for Glasgow was me actually.
Yes,
we have had one come back from Queen Square.
That's in London.
That's right, he's working with me now. I have somebody at the moment at Southampton. I expect him back later this year. And I have somebody hopefully going to Glasgow later in the year. Some other man has just joined me so that in another 2 or 3 years, he should be going out. And we hope that this can happen every year. We have at least one person joining us, and it is a continuous sort of thing.
Continuous process.
Yes.
Thank you very much. You've talked about personnel. What about facilities for them to work?
No,
facilities like equipment and...
Now, equipment, you see, if you agree that where you have a good general surgical facility, a lot of neurosurgery can be done with the addition of specific instruments and facilities. Then our Mombasa and Kisumu is well set for that. I do myself do some work in Mombasa, go down once every 3 months. So that area, in fact, you can do neurosurgery there quite well. We have developed that. Yeah. I go to Kisumu also once in a while. And again, we were on the way to developing that. And I think that we have, our own Ministry of Health is very concerned about this. The current Director of Medical Services, a colleague, is just left the University of Nairobi for this the current responsibility. And we are working together quite well.
What about diagnostic facility?